And we are live, Senators.
All right, good morning. It is January 12th, and this is the Senate Health and Welfare Committee meeting. This morning, we're going to get an update from our joint fiscal on our senior fiscal analyst, Nolan Langwell, on healthcare and healthcare overview. That'll be helpful. And then later in the morning, we're going to move on to try to understand some of the basic funding for childcare and families, because next week we're going to hear a little bit more about childcare. So, Nolan, welcome. Good to have you here.
Thank you.
And why don't you just take us through your presentation?
Great.
And do you want us to stop you? Okay, you can let us know how you want.
Yes. Okay. For the record, Nolan Langwell, Joint Fiscal Office. The purpose of today's presentation is to give you a very high level healthcare system 101. There are a lot of slides on this slide deck. I'm not going to go through each of them. It's partially designed to be a reference document as well, something that you can refer back to later on when you're like, oh, I remember the guy from JFO said something about these numbers, and there's a chart. So I'm going to blow through a lot of these. I'm going to stop on the slides that are important. There's a lot of information here, and we're going to be actually doing this over 2 days. So we'll do half today and half tomorrow. A lot of what's in here is really me just trying to tell you a story, kind of the story of the health system. So sometimes it might be a little bit progressive, or like not progressive, but like piece by piece by piece to build up to what I'm trying to, the point that I'm trying to get to. Feel free to stop me any point if you have questions. And another thing I'm going to say, and I'm going to say this again when I do my Medicaid overview, is that particularly when we get to like the more complicated stuff, is with healthcare, if you don't get it the first time, it's not you. If you don't get it the second time, it's still not you. However, if you don't get it the third time, it's still not you. This stuff is really complicated. Medicaid, it gets very weedy, very fast. Human services in general. I know people are coming from various levels of personal experience and professional understanding about this. So my job, I feel like, is to help build that foundation and try to get everybody on a level playing field so that when the budget adjustment comes in or the Medicaid directive, you start having a little bit more of a foundation to get there. As I've said in orientation, I feel like my job is to help give you guys the tools to make informed decisions the best that I can. So, so I'm a tool, a resource, use it. Were you raising your hand?
Chair, can I ask a quick question? And I should have asked this yesterday, but what's the difference between the filming that's happening here and the filming that's happening there?
Oh, okay, thank you. That's a very good question. That is PEG, public television, ORCA in this part of the world. In our part of the world, we call it Channel 17, CCTV. So they're, are you sending it directly out or recorded?
Recording.
You're recording it, so that it'll go out at some point in this area, perhaps other parts of the state.
Great, thank you. Sorry about that.
No,
That's the
fine.
difference.
Okay,
Good question.
like I'm live. Well, I'm live here anyway, so I guess it's no different. I didn't mean to give you a hard time. So I'll just start with the basic caveat of that. I'm going to throw a lot of different numbers at you throughout this presentation. I generally try to flag what year it is, if it's 2019, if it's 2022, but just with the understanding that a lot changed during COVID. COVID really shook up a lot of our consistent trends and made things very inconsistent. So it's just more me just caveating things. So you might see some things when there's a drop. I'll probably try to explain when those happen, but this is that sort of new reality, the new world that we live in, sort of post-COVID. Now, also finally, I try to break this presentation into 4 pieces: patients, providers, payers, regulators. If I am talking too fast, let me know. I'll try to slow down. I'm just going to try to cover as much information as possible. And also, I feel like with the chair's blessing, just I think ask questions as we go. If you have a question, just ask. So we'll start with patients. This is really just a population slide. again, just high level. You can see our population really didn't change much until about 2020. I won't get into the population demographics, but we've all heard the stories. Again, this is sort of our tradition. Now, we've heard a lot about, Vermont has an aging population. Well, this slide shows that. You can see that our 18 to 24s have remained flat as the red line. Our 0 to 17s have gone down, our 65 plus have gone up. So this is a consistent problem. And this is a theme within the healthcare system too. And you'll see that later on as we see some of the shifting of who's moving to what payer source and where are our expenditures. I'll skip over this. So healthcare expenditures, this is just meant to give you a picture comparison to the United States. In Vermont, our overall health expenditures in the state of Vermont were $6.37 billion in 2020. We have a 2-year lag on some of our data. This is from the Green Mountain Care Board. I always try to give the most up-to-date number I can. If it's an older number, that's because that data isn't available, or like with this particular stuff, there tends to be a 2-year lag in that data. The equivalent spending in the US was $4.1 trillion. You can see that our spending from 2019 to 2020 went down. The US still went up. This is a pandemic effect type thing. I don't know why ours went down and theirs went up, but it could have been because the federal spending offset a lot of that. I don't know what the story is there yet, but our per capita spending is still lower than the United States. $9,900 per capita, almost $12,000 per capita at the state level. Again, kind of the nation level. Again, you can see ours is sort of dropping, and the federal government has gone up. But our state gross product is a little bit higher, roughly equivalent to the United States. This really is a pandemic slide. As you can see, this is our overall spending and the growth in spending from 2012 to 2020. It has traditionally gone up. You can see in 2019 it actually dropped almost 2.5%. That's the first time that there's ever been a drop that I can remember in health spending since we've been recording this stuff. Again, that's a pandemic effect. But nonetheless, I want to show you that we talk about healthcare costs are going up. This is one of those things that shows. This is overall health spending. Now, when we talk about health spending, there's 2 ways of thinking about it. One is how much we spend how much is spent on behalf of Vermont residents. So that would include, if I go skiing out in Colorado, I break my leg, this would count as and then we have our provider perspective, which is, I go to Colorado, I break my leg, it doesn't count. But someone from Colorado is skiing at Stowe, breaks their leg, it does count, right? So there's 2 ways of looking at it. When I am giving numbers, I'm generally coming at it from the cost on the resident side, because that's often our perspective. We're thinking about things in terms of the residents of our state. This is the resident spending. So it's we've spent $6.3 billion total across the whole healthcare system. This is just another slide, just sort of comparing national to this federal. I'll go through this. We'll move on to providers. Hospitals. I'm going to talk about the different providers in the system. Hospitals are our biggest. There are 14 hospitals in Vermont, all of which are not-for-profit. I don't know of any other state that has a full not-for-profit health system. We have one level 1 trauma center. That's the University of Vermont Medical Center. There's also Dartmouth-Hitchcock, which is not in our state. We don't regulate it, but it's part of the Vermont health system. But our numbers, so when I talk about the resident expenditures, it would count Vermonters who go to Dartmouth-Hitchcock. We also have the VA, which is Little Junction, and then there's the psychiatric care hospitals, which is the Psychiatric Care Hospital in Berlin, which is run by the state, and then there's Brattleboro Retreat. You'll be hearing a lot about both of those in the coming days.
So one question about the hospitals. We also have the UVM Health Network that affiliates with Plattsburgh, and then a number of folks in the Bennington area access Albany. So but they are not. How do we?
We regulate health facilities
We
in the
don't
state of
regulate
Vermont.
them at all, or but our Medicaid dollars might, and Medicare dollars might flow.
Yeah, I mean, if you have a Vermont resident who's covered by Vermont Medicaid and they provide a service and they go out of state,
Yeah.
Medicaid's gonna pay because that Medicaid is their provider.
Yeah.
Or their payer. And vice versa, we have people who come to Vermont who might be on Medicaid, and that out-of-state Medicaid will pay as long as it's within their rules. Spending on hospital care was $2.2 billion. This is a 7% increase. This is 34% of all health spending in Vermont is hospitals. So that's 6.4. You can see 34% of that is hospitals. There are a total of 214,000 visits to emergency rooms in Vermont. University of Vermont Medical Center accounted for 23% of those, followed by Rutland, which was 12%. 12.5, UVM also accounted for about 12.5 of these emergency room visits resulted in an admission in the hospital. And then roughly 1/3 of these visits were paid for by private insurance. There were 41,000 inpatient discharges. Those who were 65 or older accounted for half of all those inpatient discharges. Medicare was the principal payer of 50% of those times. The average length of stay was 5.3 days. And again, University of Vermont Medical Center was the biggest player. They accounted for 45% of all inpatient discharges. And then there was 114,000 outpatient visits. Again, University of Vermont Medical Center accounted for 45% of those. And Medicare paid for like 50% of the time. So you're starting to see the trends. This kind of gets into the in-migration, out-migration question you were talking about a moment ago. This shows you sort of where patients are coming from in the state. So statewide, 13% of total, this is on discharges, 13% of inpatient discharges were for out-of-state residents. Of course, that varied depending on where you were. So if you look on the chart on the left, you can see that in Bennington, 30% of their inpatient discharges were from out-of-state residents, whereas North Country out-of-state discharges accounted for a much smaller piece of their. What this doesn't count, again, is that flip side of how many Vermonters are going to Dartmouth-Hitchcock. Quite a few. Years ago, the number was close to 20% or something in there. It was a Vermont residents accounted for a very noticeable margin of revenue for the university, for the Dartmouth-Hitchcock system.
So you said it's 20% of Dartmouth.
It used to be somewhere in that range. I couldn't tell you what it is now, but I remember, I'm vaguely remembering that it's not an insignificant number of Dartmouth-Hitchcock's business, and vice versa. They cover a big chunk of Vermonters. You're looking at which side of the lens you're looking at. I threw out 20%. Don't hold me to it. That's a number I remember reading years and years and years ago, somewhere in that range. But I would not say that. I shouldn't have said that. Oops. So another important piece of our health system are what known as federally qualified health centers, FQHCs. You'll be hearing a lot about them. They're an important part of our primary care network. You'll be hearing, I assume at some point, from an organization called Bi-State Primary Care. They're the trade organization for the FQHCs, and they're the ones who represent the interests of the FQHCs in the State House and throughout the state, actually throughout New England. It's a reimbursement designation from the federal government. They're reimbursed differently than regular providers. They have a larger regulatory burden in order to get those special reimbursements through the federal government that include about 90 requirements or more to keep that FQHC status. And in return, they get a better reimbursement schedule from Medicare than regular other providers. But they have to meet standards in order to maintain that. Some of the defining components would include they offer comprehensive services, including primary medical care, dental, oral, other mental health services. They generally need to be located in an area of high needs, so a place that might not normally get healthcare services. That's why you often see them in more rural areas. They have to have a patient majority governing board, and then they accept all patients regardless of payer or ability to pay, and usually and have to offer a sliding fee schedule. So you'll hear more about them in the future.
Chair, can we just ask questions?
Yeah, go ahead.
Okay.
Yeah, go right ahead.
Would, for example, in Burlington, would the community health center be an example of an FQHC?
This is just a list that shows you kind of where they're at and the number of people they served. 2020, it's 170,000 Vermonters. So they're not an insignificant part of the system. And they provide critical services, critically needed services. Another part of your jurisdiction you're going to hear a lot about is long-term care. We have 37 nursing homes, 34 of which participate in Medicaid. As of October 2022, that was about 2,800, almost 2,900 beds. I say that because the numbers of beds often fluctuate. Sometimes the beds fluctuate because of licensing. Sometimes they fluctuate because nursing home goes out of business. And sometimes they fluctuate because of staffing. They might not have enough staff to staff those beds. So there's a lot of factors that go into those numbers, but they fluctuate. We have 10 home health agencies, 17 assisted living residences, 100 residential care homes, 10 hospice programs, and then what is known as an ICF-ID, which is an intermediate care facility for individuals with intellectual disabilities. It's a group home with special needs. Mental health, you're going to be hearing a lot about whether, if you haven't already, I know that you had Commissioner Hawes on the other day, so I imagine she talked about our designated agencies. So we have 9 designated agencies. They're an important piece of, they're a critical piece of our mental health and developmental disability network. I won't go too much into these because I think I would defer to them to tell you more about it, but it's just in here as a reference. And again, and they are a critical and important part of our mental health system. We do have, I did mention, we have we have 193 adult psychiatric inpatient beds across the system. These were numbers I got back in October. Again, they might have fluctuated. Some of the beds, again, might be closed because of staffing, but these are the amount for which they're, I believe, licensed for. So we have 25 at the Vermont Psychiatric Care Hospital. We have 24 at Rutland, 80 at the Brattleboro Retreat, 14 at Central Vermont Medical Center, 12 at the VA, there's 28 at the University of Vermont Medical Center, and at Wyndham.
So I understand we're early in your presentation. I don't want to jump too far ahead, but this is all about capacity. And I'm wondering if you're at some point going to touch on need. Is that part of this analysis or not? Is 193, okay.
I don't know that I'm going to get to need in a direct way. It's probably going to be more in an indirect way in terms of showing you, when I get into like services and payers and uninsured rates and those kind of things. So it's a little more indirect. I mean,
Well, yeah, so, but we'll be bringing folks in so we can
Yeah.
understand where the gaps
Sure.
are. Yeah,
Yeah.
that right now,
Mhm.
long-term care and mental health have significant gaps and problems. And so we'll hear from the different providers,
and the budget, it'll be in the budget
hospitals,
adjustment.
VAs, everyone is implicated in what you're asking about.
Yeah.
So this just gives you I think this is important to understand what we do have, because then as you hear about the gaps, it could be workforce gap, it could be a bed gap, it could be a full facility gap, so all the different elements.
I think the different constituencies will be coming in to tell you what their needs are. And I'd rather them be the ones to tell you what they need.
We want you to.
Well,
If I could just piggyback on what said, I believe that this is so great, and it'll be even more powerful when it's put into a context that these real world lived experience things.
Yeah, this is just meant to kind of
Yeah.
lay the groundwork so when people come in, they're like, oh yeah, there was a slide on that. How many beds are in the system? Oh yeah, we talked about it.
Yeah,
It's in the
so when somebody
presentation.
says Brattleboro Retreat, you say, oh, let's see, I want that.
I've been doing this presentation for a decade or more. And I recently added the workforce slide in here because this is a really critical piece. During the pandemic, there was a lot of conversations about workforce. Workforce is, as you know, it's something that's one of the biggest needs in our system. And so these are some data. They're from varying pieces. But again, this slide is going to start telling you a story. So this is 2018 data for physicians, but you can see there was about 2,473 physicians, or roughly 1,400 FTEs that were providing care. Quarter of those were in primary care, and 75% of those were in specialty care. You can see the trends were in primary care, we had fewer and fewer, with 21 less FTE, or 21 less physicians and 33 less FTEs in 2016. And in the prior survey in 2008, there were 19 less. There seems to be a trend of less and less. If you look at specialty care, there were 312 more. So you can see that we're getting physicians, but they're often going into specialty care. And I won't go into the reasons why, but we have heard those and you will hear those again. But that sort of highlights, there's a need across all of them. We need specialists, we need primary care, but this sort of helps show where people are kind of going based on this. That's the story that this survey is telling.
Got two questions here.
Nurse practitioners, so is that
Next slide.
okay,
On this slide, in my world, FTE is full-time equivalent, same.
Yes. I should have said the clarification. Another piece is that when we've talked about workforce, we've talked about our different programs that we offer in the state. So 33% of physicians attended medical school or had a residency in Vermont. And then 30% are under 44, 30% are over 60. So again, I'm just trying to give you a sense of the workforce. Physicians' assistants are becoming more and more an important part of filling that gap. We had 355 physicians' assistants in 2019. 111, 31% of those were in primary care. 70% of those were in specialty, mainly. Again, you can see that the trend, fortunately for PAs, is it's going up. We tend to have a little bit more going than we did in the previous years. It seems to be moving in the right direction for both specialty and primary care. However, there are no there's no PA program, training programs in the state of Vermont. So all of our physician assistants that come to Vermont are coming from out of state in terms of training. They might be Vermonters, but they're coming from out of state. Most are under the age of 44. So you get a sense of kind of demographic of that population. So it kind of shows that they're helping to sort of fill in some of that important gap. Nurses. This is various use of data, but we have our advanced practicing registered nurses, our RNs, our LPNs, and our LNAs. So I won't walk you through the slide of each particular one, but again, the story is showing you that number we have licensed in Vermont, the percentage that are actually practicing in Vermont. The average age you can see is between 40 and 50. How many are under 44? How many are over 65? How many are sort of looking to further their education? What percentage are full-time? What percentage are traveling nurses? So this again is helping you tell the story of what our nursing workforce looks like. Dentists. We don't actually talk a lot about dentists in the legislature. Yes, except for Senator Hardy. There are 389 dentists. Most of those provide mainly primary care. Again, I break out the age break so you get a sense of where our dental workforce is. And then this has sort of been staying the same. The net number of dentists stayed the same between 2017 and 2019. However, more were providing 30 hours or more per week. So that increased as the full-time equivalents by 3.3 because they increased their hours. The percentage of dentists accepting new patients was 97%, so that was good. But only 55% of dentists were accepting new Medicaid patients, and that's a problem, particularly because reimbursement rates for Medicaid is extremely low. So now we're going to move into the fun stuff, or the beef. We're going to move a little bit more meatier, not meteor shower, but meatier. So this is at a high level. This is what our insurance coverage looks like. I tend to think about things in terms of private and government. So in terms of private insurance, we have our employer base, we have our individual market, and I'll get into a little bit more of the details in a future slide. But what's also important here is to see that, okay, 49% of Vermonters have private insurance, 24% have Medicaid, 21% have Medicare, and then we have 3% of military, and then we have a 3% uninsured rate. Yes.
Do you know how that 3% uninsured compares to the nationwide?
Yes, they're much lower. I don't know what the national rate is. It's probably at least double that. Vermont and Massachusetts traditionally have had the lowest uninsured rates in the country. No one has really gotten below 3. I think that's sort of like.
And can you characterize the sort of the group that's uninsured? I mean, different groups within that category.
I have a slide later on. So there's a document called the Vermont Household Health Insurance Survey. And I can send folks a link. I get a lot of this information from that. They have a whole section on uninsured and underinsured, and ask, well, why do you not have insurance? And there's various reasons. Number one reason is cost.
There's also a churn in people as they switch health plans. There are also a number of people who don't have it are undocumented migrant farm workers. But a lot of it is just switching between things and falling through the cracks in eligibility for Medicaid as well.
So if you could send that link, that'd be great. Yeah, because you get it to Alex and he'll get it up on our little web page.
But a 3% rate is really, really low.
Yeah.
Compared to most
It
states.
is.
And I don't know, getting from 3 to 2 is probably more work than getting from 10 to 3.
Yeah.
Right.
There's reasons anyway. This slide is another way of looking at it over time. And again, I like this slide tells a story. If you look at 2008, the number of private insured was 60%. If you look at the government, and that's the Medicare and Medicaid combined, it was 30%. So 30-60 split. If you fast forward to 2021, the number of folks on private insurance decreased to 49%. The number of folks on Medicare and Medicaid increased to 45%. So we're seeing a shift of folks from private insurance as their primary to some form of government. Now, there are a lot of reasons for that. We have an aging population, so we have folks that are going to Medicare. Between 2008 and 2021, we had the Affordable Care Act. We've had a lot of initiatives in Vermont, Medicaid expansions to try to move more people to get more people covered, because the uninsured rate was 8%, and now it's 3%. So a lot of those folks went to Medicaid. So we had expansions. We have policies that have tried to encourage folks to enroll in Medicaid. There's another small piece that's not represented in here. You're going to hear about this. I'm going to go a little off script for a second, but we are in the middle of the corona. I have this in this presentation I'll give to you tomorrow, but I'm going to give it to you now too, and just tell you the story. There was the Coronavirus Relief Act, one of the federal bills that passed. And what it did basically was it gave states an additional federal match for their federal matching rate. And I'll get into federal matching rates later, but part of in order to receive that money, one of the requirements is this thing called maintenance of effort, maintenance of eligibility. And in short, normally Medicaid has what we call churn. Senator Hardy made me think of this churn. You have people who come into the program, people who come off the program, and that's because there's a thing called redetermination. Annually, people who are on Medicaid, there's a system that looks at their eligibility. Are they still eligible? Did their income go up? Did their income come down? Did they get insurance elsewhere? And so we tend to have this churn of people coming on, people coming off. The trend's still going up because we have more people traditionally coming on than coming off, but it's a steady trend. When the maintenance of effort goes into place, we can't do redeterminations while we're getting this additional match, because there's this requirements that say you can't change the eligibility rules, you can't do redeterminations, et cetera. So what happens now is people are coming on, but they're not coming off. So we're seeing this spike in enrollments that's going up. And you're going to hear about that in budget adjustment. It's going to be a piece of that. You're going to hear about that in the budget. Now, yes, spending is going up, but it's not commensurate. Just because people are staying on it doesn't mean we're seeing the same spike in utilization. We are seeing increased utilization for sure. But just because people aren't being disenrolled doesn't necessarily mean they're using services. Many are, and there's definitely an increase in cost, but that's part of what that additional federal match is doing, is providing that fiscal relief to the states. So without getting too much into the weeds, that's a piece that's going to skew the numbers in the future. But there is this piece, and I wanted to give you a little bit of foundation when DVHA comes in, does their budget adjustment and talks about how our caseloads have changed, or the caseloads increased and utilization increased. Redetermination is part of that story.
And that's the thing I asked the secretary about yesterday, was the redetermination. Because once the public health emergency ends, redeterminations are supposed to restart, and then there'll be more people coming on and off of Medicaid because of it. But there's some complicated timing happening with the redetermination restart and the public health emergency ending. And that's going to cause some complications with the numbers. And that's what I was asking the secretary about yesterday when she was in.
And I shared the stage with Ashley Berliner yesterday, and she had a little bit more information on that, and she talked about some recent federal legislation that is addressing it.
We're gonna get you and Ashley in so we can
Yeah,
come
I
back.
think next week, right?
Yeah.
Yeah,
Is
so
it
we'll
next
talk, we'll
week?
get into that, or
Yeah,
you can
so
ask
we'll-
her about it. She knows more about it.
Yeah, no, I've talked to Ashley about it.
Okay.
Yeah.
Yes, we can get everybody here, and then next week we'll get everybody here.
Yeah.
Deep dive.
So make sure I'm understanding the jargon or nomenclature.
I was gonna say it, I'll never,
I know.
one more time.
Well, so, yeah, is redetermination the same as churn? Are they sort of the same thing?
Sort of. I mean, yes, redetermination is an element that that controls churn, or is a factor in determining the level of churn.
Gotcha.
Because we have churn in all types of things, private insurance as well. But redetermination is a factor, is one of the major elements in the Medicaid churn.
Gotcha. Thanks.
Okay, so you told us that if we didn't understand it the first time. So the difference between churn and redetermination, if you just.
So redetermination is a policy, it's a technology, it's a technique. They go in and every year they look at eligibility. People have to submit documentation and they say, okay, you're eligible, you're not eligible. So churn is, the normal flow of things. I'm new to the program. I come in, you've been on the program and you've got a big wage increase and you got a new job and you have private insurance, now you come off. That's sort of that natural flow of things and, the levels of it. And now with redeterminations not being there, you got a new job, we don't know, you're still technically on the Medicaid books. So there's no churn anymore because redetermination is on pause. So go back on script now. I like this slide. This is from the Green Mountain Care Board because it kind of shows you where spending is. You can see, so for instance, the government spending, so that's Medicare, Medicaid combined, and then the red is private insurance. So you can see for things like home health and nursing homes, large part of those is government spending. But when you look at like, you start getting into physicians and hospitals, it's about even with spending. Then you start getting into like dentists and other stuff, then it starts being more private insurance. So that's just, I like this because it kind of tells a little bit of a story. We'll start getting into a little bit of the weeds now of the breakdown of private insurance. Again, remember 49% of Vermonters are covered by private insurance. I'll talk about this first. So the majority of private insurance is employer-based, meaning that folks who have private insurance are usually getting it, majority of those folks are getting it through their employer. So those would include folks who are self-insured or insured. And I have a slide down the road that tells you the difference between a self-insured and insured. So I won't get into that for a second. But you'll hear the term large group, small group, individual market. And that has to do with the size of the group and the type of insurance and the size of the employer. So if you're an employer over 100 and you're not self-insuring, you're usually a large group. This particular population is a smaller group. The self-insured group is a larger group of people that are in that. And then there's a small group, which is 100 or less. So if you're an employer who offers insurance and you're 100 or less, you're considered a small group. And then the individual market is folks who do not have insurance through the employer. They might be on the exchange. You can buy small group and individual group plans through the Vermont Exchange, Vermont Health Connect. And I'll get into a little bit more weeds on that in a moment. But this is a slide that I wanted that actually Representative Houghton asked me to put in here, which I think is an important piece. This is sort of like when we talk about who the populations of the segments of the market for which the legislature has some regulatory control of some sort. We have, or as I like to say, influenced by the state. So we regulate individual market group, the small group, and the large group. We regulate them through the Green Mountain Care Board, who does, these insurance companies have to file rates with them, and they look at to see if the rates are reasonable, and there's a role for the healthcare advocate in that process. Also, the Department of Financial Regulations looks at the rates for solvency to make sure there's enough reserves and that they remain solvent. The other piece that we regulate is Medicaid. Well, we as the state are the payer, we are the provider. So we, or you, regulate them through the state budget process and through other pieces in terms of like, well, we want Medicaid to cover this, we want Medicaid to cover that. And that's what we're going to get into next week when we start talking about a thing called global commitment. Global commitment, just to sort of put it out there now, is the name of the agreement that between the state and the federal government for how we administer our Medicaid program. And that includes what we cover, who we cover, how much it costs. So that I'll get into a little bit later on as well. What we don't regulate is all the white. So obviously we don't regulate Medicare, that's full federal. You know, we don't regulate military insurance, that's the military. We don't regulate the uninsured because they're not regulated. And then there's the self-insured group, and you can see that's a pretty big chunk. Self-insured group, I'll get into it in a later slide. It's actually the next slide, so let me segment into that.
In terms of the uninsured and those folks, we do have clinics that provide services for them, and so that includes some of the non-residents, undocumented, and it also includes people who don't have insurance. So there's one in Barry.
Yeah.
There's one in Barry. I know there's one in Addison County. So there are clinics around that do support people that don't have the coverage that many do.
Real quick, I just want to let you know that the reason I'm coughing is I've had that respiratory thing over Christmas.
Oh, gosh.
And now I've got that cough that never goes away.
Oh.
I promise you, I've taken a lot of COVID tests. I'm not sick. I just have when I talk, I have a very dry throat. So I'm just letting you know that I do not have,
water there.
I don't have RSV. I did, I think, I don't know. But anyway, I had a respiratory thing over Christmas and I'm still coughing. I have asthma too, so that's fair. So just to set your mind at
This
ease.
is a good committee to be in then.
Just to set your mind at ease, like,
We'll
I'm not
take
sick,
care of it.
I'm not contagious, I usually wear a mask anyway, and I don't have COVID, so.
I have it too, and it lingers for a long time.
Yeah,
Just a little.
I did have a question about the slide.
sure.
I'm confused. The title of the slide is private commercial insurance.
Mhm. That was because when I made the slide, I cut and pasted the fires. So I have all the backgrounds, and I didn't change the title, I probably should have.
Oh,
I should have called it,
So what should the title be?
that's
title should be,
not private, not.
no, the title, thank you. You know, this is one of the things when you start, you know.
State influence?
No, it's just really.
Yeah, like regulated, influenced by the state.
Gotcha, okay.
Thank you for that.
No, thank you, I was really.
You know, there's a lot of slides and I upgrade them and you spend so much time in something, you start losing sight of things. Thank you for that.
No, thank you.
And also it's kind of in that section of things, so real quick, insured versus self-insured. So when we talk about insured, we're talking about like, for instance, large group or the small group market. And in that case, it's like, I'm a small employer or I'm a large employer. I decide I want to offer insurance to my employees, and so I go to Blue Cross Blue Shield or MVP, and I buy a plan, you know, a whole plan for all my employees, and I pay, maybe I'll pay 20% of their premium, and I just pay a premium every month. Self-insured is where the employer basically assumes all the risk. They don't, instead of like paying for an insurance plan where the insurer, I'm paying the premium, and then the insurer, I'm paying for them to have the risk. Self-insured is where I'm saying, you know what, I think that I can assume the risk. I think it's cheaper for me to pay for those claims when people get sick than for me to pay a premium every month, which is why a lot of times you see large companies doing this and they have wellness programs and all these other things. So they think like, you know what, I have a healthy population. And if I put these things in place, I make sure they have their immunizations and I give them bonuses for walking 100 miles and, you know, like those kind of things. But what they still do is their card might still say Blue Cross Blue Shield on it though, because what they're doing is they're hiring an insurance company to be what's called a third-party administrator, or TPA. And the insurers offer products for companies like that. Well, they have all these different benefit packages, and they just administer the claims. But the employer bears the risk. They'll pay the cost. Someone gets sick and goes to the hospital, the employer will pay it. But it's still, but they're balancing, they're looking at it as a risk benefit analysis in terms of like, I think I have, 1,000 employees. And if I have 2 people that are sick, like, so it's a business decision. And usually if a company is self-insuring, they've done the numbers and said, you know what, I think this is a better risk for me to do it that way. There also, the difference is regular insured products like small group and large group, they're subject to state regulations. So for instance, several years ago, we put in a mandate that they have to do, insurers have to cover colorectal screenings or have to cover mammograms. So insurers have to cover those, but self-insured do not, because they are not regulated by the state. They're regulated by what's, and I don't want to get down this road, this thing called ERISA. And it's got some employment, retirement, I don't know what it stands for.
Something insurance, something.
Yeah, something out.
Right.
And basically it's a federal law that goes, it covers a lot of things, but I don't think we need to get deep into it, but you'll hear people call it ERISA plans or self-insured plans. It's the same thing when people they're using those two interchangeably. But in short, if it's an ERISA plan or self-insured plan, like we have no regulatory authority over those plans.
So, and I just will say, and Senator, when the federal law was passed, there was a huge discussion about self-insurance and whether states could regulate and at what level. And Hawaii does not have, Hawaii was excluded from that. So they now have that authority to regulate insurance overall, including ERISA plans. And then there was a period of time in my history in this building when we had some legal analysis of to what extent can we
Mhm.
regulate ERISA? And there's a difference of opinion about that. We won't talk about.
It's a rabbit
the legal,
hole.
the
It's a very easy rabbit hole to go down.
Some yes, some no. So it was a legal debate about that. And then, so we continue to look at how we can provide oversight for self-insured plans to ensure that that people are covered effectively. So that, we will come back to this at different stages. We may see something, we don't know.
So if we were to today, which we can't really do because there's all these other implications, but if we were to do another mandate saying we want to cover hearing aids, I'm just gonna throw that out. We would only be affecting that small light blue sliver of the population in terms of being required. Of course, then we'd say, well, we're gonna do it for that. We want to do it ourselves and cover it in Medicaid, but that's a separate decision. Where we're saying, if you're gonna mandate commercial have it, then we should, and then it's a question of whether we should make Medicaid do it as well. But that said, doesn't mean that those private insurance, that there's a risk plan aren't already covered that. In many cases, we found that we were covering, when we said we were doing mammograms or other things, a lot of times, like, I think it's time IBM and other large employers were like, yeah, we're covering that already, so it's not like, right, ever, some of the mandates have done, I don't remember if they were doing that one specifically, but a lot of times these bigger self-insured plans often cover a lot of what we're covering anyway, but we can't tell them to do it.
I think Senator LaRock, would have a question.
Thank you, Chair. Yes, I do. Next one, please. Yeah, could you, just for clarity, give us an example of an organization that would fall into that self-insured category?
Yeah,
Millbury College.
Global
Yeah.
Foundries.
University of Vermont Medical
UVM
Center,
Medical Center.
state of Vermont, sort of.
UVM.
We're self-insured, but we're public self-insured. It's got slightly different rules. I won't get into that, but theoretically, the state of Vermont is self-insured.
Okay, and should you do the same for the insured?
Yeah, small lawyer practice.
A lot of small businesses.
Nonprofits,
Nonprofit, all of them.
legal aid.
Thank you.
The Craftsman Group.
Go ahead.
Oh, no, you're
We're on the individual market.
Oh, okay, there you go.
One question, what I understood before I came to this door was Medicaid, state, Medicare, and federal. And how many insurance companies are actually allowed to operate the state?
So, great question. There are a lot. I don't have the list, but there were somewhere between, there's probably at least 50. And so I've seen this report that Department of Financial Regulation puts out, and they have every insurance company that has somebody covers some Vermonter in the state. So you might have some small, like something mutual of Omaha might have 3 people from Vermont, but that's because those 3 people work remotely and they work for a large company based in Oklahoma. But they are, I think that they're I believe, I'm not a lawyer, they may be subject to some federal to state regulations. But to answer the bigger question is, the vast majority of Vermonters are covered by either Blue Cross Blue Shield of Vermont or MVP. The 2 of those combined are somewhere between 80 and 90% of Vermonters, or have some, and that includes self-insured who have them through a TPA.
Is that the case with Medicaid?
No, Medicaid Medicaid is its own insurance company. Medicaid is not self-insured. Medicaid administers the product, processes its own claims. It technically is an insurance company, but it's not really an insurance company.
Yeah, so there's got federal rules and guidelines, and then we have state rules, and it's within DEVA, Department of Vermont Health Access, in AHS. So, DEVA, and that's where Medicaid sits, but then there are other, remember, little pieces of Medicaid in different parts of the agency. It can get complicated quickly.
I'm sure it'll get clear.
Yeah, you will. You'll get more comfortable.
And to clarify, when I say 80-90%, I meant 80-90% of privately insured.
Yeah.
So 80-90% of that 49%. There it is. So here it's sort of that breaks out that private insurance group. So you can see of that private insurance, of that 49%, 74% are self-insured. 15% are small group and 7% are large group. So 3/4 of that 49% are employer-sponsored plans, which includes the military, because the military is technically an employer, and they have their own thing. But you know more about it than I would.
Well, I'm not sure, so the 3% military roughly for the overall population, is that active duty or retirees?
I believe it's active duty. I don't know about retirees. It's about 16,000 folks, and I'm not sure how they're calculated in that particular, in the health insurance survey. I don't know if they're
Tricare for what is Tricare?
I believe it's TRICARE, but
That's for the military and the water.
good question. I don't know the answer. All I can say is 16,600 for Vermont military, care in the military. It's a primary. So Vermont Health Connect, or the Health Benefits Exchange. This is something you'll hear a bunch about. The health benefit exchanges were created by the Affordable Care Act, and they were designed to be these online marketplaces for the individual and the small group market or small businesses, again, employers under 100 or less. There's a place for people to be able to buy health insurance. It is administered by the Vermont Department of Health Access, which is our Medicaid. So technically, it's administered, the online marketplace is administered by Medicaid. And the reason that is because they administer subsidies for folks, but it's one-stop shopping. So this is the breakdown of the folks who are on either. So of the small employers, again, we can find them up to 100 employers. There's 40,000 people roughly who are in the small group. And then on the individual plans, that's the blue and the yellow, it's approximately 30,000 folks who have individual plans. 3/4 of them receive financial assistance, and that's both state and or federal. So the different assistance programs that are out there is you have what's called the Federal Advanced Premium Tax Credits, or APTC. Those are for folks up to 400% federal poverty. And before you ask me what 400% of federal poverty is, I'm going to give out a chart. If you go to the very, very last page of this printout, I have a field chart. You can look it up. But essentially 400% of federal poverty for individual is $54,000 a year, and for family of four, it's about 111. I usually have an FPL chart, but I gave one to this group.
Yeah, we should probably put one back up there.
Yeah, I usually give them to my committee so that they can
Yeah, it's good.
look, because it's going to come up a lot. It's going to come up in the child care conversations. It's going to come up in all this stuff. Then folks also can get additional state tax credits available up to 300%. Why 300%? That's because prior to the Affordable Care Act, the state had a program called Catamount Health. We had negotiated with the federal government to allow us to subsidize those Catamount Health products for folks up to 300%. So when the Affordable Care Act passed and Catamount and BHAP, which was another program, had to go away, we were able to negotiate with the feds for us to be able to have state match dollars on subsidies up to folks up to 300. We wanted to do 400. They said, nope, 300 is where you are for Catamount. That's where you're at for this. So the advanced premium tax credits essentially are through the tax system, but they help lower folks' monthly premium. And
Maybe at some point, and you don't have to do it now, so I don't want to interrupt your flow, but talk about the value of having a higher risk pool, a higher number of covered lives, and how that helps to lower costs and risk, you know,
Yeah, that's a whole insurance
that's
conversation,
all. of it.
which, by the way, I have a whole presentation on insurance coverage. We can
We
do
might
that.
do that, we might do that.
Okay, you
Yeah.
can put me on the agenda for that if you want.
Yes, well,
I'm doing it for house healthcare next week, so.
okay, well,
But I do talk about risk pools. and-
Yes.
And again, weeds about deductibles and copays, and so yes. So you can go down, there's so many,
Alex is making a
Tentacles.
note that we want to have you do the whole insurance overview.
so in addition to tax credits, which help reduce folks' monthly premiums, there's also what's called cost sharing reductions. There's federal and there's state cost sharing reductions. Again, you know, the state, we cover them up to 300% of federal poverty. And what that does is, in addition to the premiums, it also essentially it decreases out-of-pocket costs, essentially helps folks. So that their out-of-pocket cost liability is reduced because the state is subsidized, the state and federal government are subsidizing that as well. But in order to get those, you have to buy your insurance through the exchange. Now, if you're someone who's over 400% of federal poverty or doesn't, not eligible for premiums, you don't have to, any kind of subsidy of any sort. You don't have to buy through the exchange. You can buy directly through the insurer. And in many cases, it might be better for you to do so because we have done things with the markets to try to help folks who don't have exchange to bring down their premiums a little bit. And I won't get into the weeds on that, but that goes down a really dark rabbit hole real fast. Mike knows what I'm talking about. But in short, if you're over 400% of federal poverty, you don't have employer-sponsored insurance, and you have to buy an individual market, you can just go to insurers directly. As a matter of fact, I'd recommend that. But you still could. Mike wants to say something. Can I phone a friend? Claire wants to say something.
Absolutely.
At least for the next.
Introduce yourself.
This is Mike Fisher, healthcare advocate. At least for the next 3 years,
Yeah.
through the enhanced premium tax credits, there is in effect not a 400% cap on premium
Oh,
tax
that's
credits.
right.
A cap on the percent of income
That's right.
for the family.
So temporary, for the federal premium tax credits, it's above 400 now temporarily for one of the coronavirus
Right.
relief
They
pieces.
did a lot of temporary things during COVID.
Yeah, that's another piece I should,
And it's kind
I think it
of,
was in the Inflation Reduction Act, actually.
Yeah.
yeah,
yes, it is.
Both in ARPA initially.
That was in the IRA. Before October.
Yeah.
See, this is why we phone
When
friends.
you're comfortable leaving it.
I don't think this is.
No, yeah.
We were right.
We were right.
So real quick, as mentioned, there's 16,000, 3% of folks that have military coverage, covered on current and previous military service, and that includes the VA. And again, I couldn't tell you if it's retirees are in there or not, that's a good question. The uninsured, you can see that from 2012 to 2021, the number of uninsured dropped. So in 2012, we were at 6.8%, and in 2021, we're at 3.1%. I get this information again from the Vermont Household Health Insurance Survey. Of those who are uninsured, 20% were actually eligible for Medicaid. This gets into the how do you get below 3%. A lot of folks were eligible for Medicaid, and for whatever reasons they didn't apply it. Maybe they didn't get sick. Sometimes they don't want the stigma. There's multiple reasons why folks were. 52% of those uninsured were eligible for state or federal tax credits, or any kind of subsidy. And another 33% of those had access to some kind of form of employer-sponsored insurance. The most common reason cited why they did not take their employer-sponsored insurance was that it cost too much. Cost was the primary reason. So we're trying to get into some of the reasons why folks may or may not have insurance. So a lot of those folks have access to insurance, but they do not take it for whatever reason, usually cost. And obviously I threw this in here because of the pandemic, but this is from the survey. And of those who were unemployed or furloughed during the COVID-19 pandemic, 84% maintained coverage. So this is important because even though people might have lost their jobs and furloughed, a lot of companies kept people on their rolls, kept them insured, or people paid for COBRA or Medicaid or whatever, but a lot of them stayed on. And you can see, a quarter of those is because they were on Medicaid or Green Mountain Care, which is Medicaid, or they had it through a spouse and they paid COBRA. So in short, COVID-19 did increase the uninsured rate a little bit, but not as much as you think. So people maintained their coverage through the pandemic. What I like about this slide is on the left is this, the same chart I showed you before. 49% of private insurance, 24 in Medicaid. This is total population. However, if you look on the right side, this is just kids, the subset. This is just kids under 17 and under. You can see that we only had a 1% uninsured rate for kids. It's only 1,200 kids in the state of Vermont were uninsured. But 52% of kids in Vermont were on Medicaid. So you can see it's slightly different looking chart. So I wanted to just sort of show wow, how we're covering kids. Now we're going to get into Medicare and Medicaid.
So I'm
is this a
gonna
good place to
say,
stop?
yeah, I think probably, and then we
Yeah.
can come back to this when
Yeah.
we get you in the next time. That would be
Tomorrow.
Great. I know. Good.
So in case I duck out for just 1 minute.
We're gonna take like a 3-minute